Next, I'll be presenting about the patella dislocation. So first is the anatomy of the patella. The patella is a triangular sesamoid bone embedded with the quadriceps tendon. The function is to protect the knee joint, increase the leverage of the quadriceps during knee extension, and also maintain the alignment of the extensor mechanism. So the stabilizers of the patella, there will be dynamic stabilizers and also the static stabilizers. So the dynamic stabilizers are the muscles. So these are the quadriceps femoris, especially the vastus medialis obliquus or the VMO, which pulls the patella medially to prevent the lateral dislocations. The adductor muscles, mainly the adductor magnus, which provides the medial pull indirectly through the adductor tubercle and the medial stabilizing structures. And for the static stabilizers, there are patellofemoral articulations, the medial patellofemoral ligaments or the MPFL, which primarily restrain against the lateral patella displacement, and the patella tendon, which connects the patella to the tibial tuberosity.
For the see that dynamic stabilizer always muscle, that is ligament.
So for the mechanism of the patella injuries can occur via direct or indirect mechanism, as well as in the high energy trauma. So for the indirect injuries, it occurs without a direct blow to the patella. It can occur with the strong quadriceps contractions. For example, the sudden forceful contractions of the quadriceps can cause the patella fractures or the subluxation or the dislocation. It is common during jumping, running, or kicking, or the knee position during the injuries, for example, the flexed knees or the internal rotation of the femur on externally rotated tibia. For the directed injuries, it occurs due to external force directly to the patella. For example, the high energy blow, the fall on the knee, or the motor vehicle accident. The force applied directly to the patella can cause these stellate fractures or comminuted fractures. So there are several risk factors for the patella dislocation. First are the muscular factors. An imbalance in the muscle forces around the patella can increase the lateral tracking and instabilities. For example, the vastus medialis obliquus weaknesses, the overpull of the lateral structures, for example, the iliotibial band or the vastus lateralis. Next is the osseous abnormalities, including the patella alta, which is when patella sits above the trochlear grooves. There will be less bony stabilities, like this one, less bony stabilities in early flexion. The trochlear dysplasia, which shows a shallow or flat trochlear grooves, and excessive lateral patella tilt, or the lateral femoral condyle hypoplasia.
So that may be complicated for you. So you imagine that the patella is sitting in the groove, right? So you need to have a good balance between medial and lateral side, and also the bone structure. So the bone structure, if you have shallow socket, you have shallow socket, the patella tend to get down. So there is osseous abnormalities we call trochlear dysplasia. Okay? So that is also very common. That is congenital. Some patients very high risk of dislocation because they have the congenital abnormalities. So mostly in women, that is girls. And the imbalance of the muscle, especially of weakness of the VMO or overpull the lateral side. Yeah. And also the alignment of the knee. You have valgus knee, you tend to have pop out because the axis of the knee tend to pull the patella to the lateral side. I mean, the vector of the quadriceps. Now, this valgus knee, you see, it tend to have the patella going out. So patella always go out lateral, not medial. Okay? I never see medial dislocation, mostly lateral dislocation.
Lastly is the lower lemur alignment, or as I already mentioned, there will be large Q angle and femoral anteversion and genuvulcum.
In some countries like Japanese, they have a lot of femoral anteversion. The patient will go like they talk walking like in toe. You have seen in toe walking? Yeah, when you have in toe walking, so the knee will be valgus and the patella tend to go out because the hip internal rotate, So the patella tend to go out. So that's also the hip abnormalities, you know. The patella dislocation is very common. You need to look the hip, the knee, the alignment, the bone, the soft tissue, you know. So if it complicated, you need to find what is the causes of the dislocation.
So next is the clinical presentation and history taking that you should know. So for the presentation, there will be visible deformities, the lateral displacement of the patella, or the obvious inspection immediately after injuries. There will be pain and swelling, the severe pain localized to the anterior knee, and also there can be the rapid swelling due to the hematosis. The instability, the patient will be feeling a bulking or giving way, and also the inability to bear weight or walk properly. The mechanical symptoms, for example, popping or clicking sensation at the time of the injuries. And lastly, the functional limitations. As already said, that patient might feel difficulties when moving the legs. For the important history taking, the mechanism of the injuries, how the injury occurs, direct blow, twisting or jumping or sudden quadricep contractions. The symptoms including location, severity of pain, onset of swelling, feeling of instabilities, popping, clicking or snapping sound, visible misalignment, and difficulty moving the knee. Also the important past histories.
So Cal, the mechanism is like when you have the history of patella dislocation, means swelling, right, and twisting injury, this mechanism same like what type injury. You need to thinking about two things at the same time. What is that? Very common.
Like similar to
Swelling,
knee dislocation.
twisting,
Oh, the anterior
giving
ACL.
way,
ACL.
ACL. So every time the patient come to see you with knee swelling, and they have the history of twisting, and sometimes they cannot recognize the dislocation because it pop out and in very fast. You know, patients say they have a twist injury and have knee swollen, pain, cannot walk. So the scenario is same like ACL. Okay? So every time you have this injury, thinking about the patella dislocation.
So next is the physical examination. For the inspection, you can inspect if there is knee swelling, deformities, patella position, alignment of the patella, quadricep muscle bulk, or the gait abnormalities. For the palpation, you can palpate the tenderness at patella tendon, tenderness and abnormalities along the poles of the patella. And also the movement, you can assess the knee range of movement, and also pain with terminal flexion or extension.
So how can you know this is patella or this is ACL injury? How can you know? How to differentiate by the history? How can you know? Oh,
Maybe if it's ACL, there will be more like swelling because the ligament is ruptured.
you cannot say like that because the swelling depends on the patient, right? Because some patients have less swelling, some have more.
Maybe like the visible deformities.
Visual deformity.
Patella
You
deformities.
can ask the patient that the first time they have any visible deformity, they are not, or they feel it like it's pop out and in. Yeah. Because many times patients have dislocation, you know how many percent they have obvious deformity when you came to ER?
40.
Huh?
20.
Yeah,
50.
people.
Yeah, around half.
Oh, okay.
So many of them, I think more than half was reduced or subluxed or auto reduction before you can do the ER. Right? So you need to ask the patient any obvious or visible deformity. But the patient comes to see you the same like ACL, they have knee swollen and hematosis. Okay, next.
Next, this is special test. For the patella, you can do the Clark test, which when letting patient supine with leg extended, placing hand above the patella and putting like the downward pressure and ask the patient to contract the quadricep muscles. You can also do the patella apprehension test. When patient lies supine with the knee extended and palpating the medial side and lateral side of the patella. And that can also be the dynamic J
You
side.
do not do that on the first time. You need to wait for
When it's
like
willing to
2-3 weeks after that. You can do a special exam like ACL. But the first time you just see knee hematosis, development positive.
So
But the difference is that from the ACL, when you touch the medial side of the knee, that will be more painful. I mean the medial of the patella. Because when the patella dislocates laterally, the torn structure is on the medial side. We call medial patellofemoral ligament. Patients have so much pain on the medial side of the knee.
You can also see the dynamic J sign. As the patient actively extends the knee from the flexed position, the patella shifts to the lateral side near the terminal extension, which there will be the video shown later. The patella gliding test, where you glide the patella and gently push medially or laterally, and the patella tilt test, where the patient lies supine with knee full extension, and the examiner places fingers on the lateral edge of the patella.
You look at the picture, you divide into 4 quadrants by half. So if you can move more than half, then that means this is blind is positive. So you can move to the lateral side.
This is the patella grind test.
The patellar grind test assesses for patellofemoral syndrome.
That will shift.
With the knee extended, push the patella into the trochlear groove of the femur.
It will be positive in PFR practice. The next.
This is the double J sign. Just want to show. Here. Yeah.
Getting out when it's back. Then this we call jumping J sign. Jumping J sign. Get out and in sudden jump. Again. The is getting out when you extend or flex.
When you extend.
Extend. You see it out. You bend the knee, getting back. See, on the right side is jumping back. We call jumping J sign. Next.
Oh, this one is the patella tilt test. Just want to.
Patient's knee extended and quadriceps rolled.
It's using for the patella lateral tightness.
Lateral borders of the patella, then attempt to lift the lateral border without gliding the patella medially or laterally. The inability to lift the lateral border above the horizontal plane may be.
And this one is the last one, the patella apprehension test.
In this video, I'm going to demonstrate the patella apprehension test to allow passive movement of the patella. With the thumb of both hands, press on the medial side of the patella to exert laterally directed pressure.
So we have N and 5 to stop.
In a positive test, the patient may be surprised.
And so this one is the Baton scoring system where you assess the hypermobility of the joint. You can choose a score, and this is if you can just see the positive Baton score reference from this. And for the radiographic evaluation, you can send the AP view of the knee to assess the alignment, the osteochondral fragment, and also the bipartite patella. You can also send the lateral view 30-degree flexion. We can assess the patella alta, trochlear dysplasia, or osteochondral fragments.
So what you have to look at is any loose fragment. Because many times patella dislocation, there's a break fracture, the small fracture. So those fractures always coming from the medial facet of the patella. Because patella move lateral, so before it's getting out, there's some impact that the medial facet with the trochlea like this. It's going out, hitting like this because it's going out. Right? So there will be fracture of the medial facet of the patella. So looking for any osteochondral fracture or loose fracture.
And next is the patella skyline version view. You can assess the sulcus angle, patella tilt.
Be like sunrise, we call sunrise view.
Oh.
It should be in the center of the, it's like a hill with the sun in the middle. It should be equal spread international.
You can also assess the avulsion fractures and, as Ajahn said, the osteochondral fractures. And for the management of the patient with patella dislocation, initial management includes close reductions, there will be further video on this, brace therapy, rest, ice compression and elevation, pain control, and immobilization using knee brace, splint, which allows to use in 2 to 4 weeks, and crutches to reduce the weight bearing on the knee. And at 3 to 6 weeks, the patient can do the rehabilitation, the strengthening exercise of the vastus medialis oblique muscle and gluteus medius muscle. And the indication for the surgical management, first is a first dislocation with osteochondral fractures or loose body. If MRI shows the disruption of the AMPFL.
No, osteochondral fracture. So the rest is, I think, too complicated. So you did not show us how to reduce the patella dislocation. You forgot, right?
Yeah, sorry, I forgot to put
You need to find the video how to reduce the patella dislocation. So it's also very simple. You just extend the knee joint. The patient that cannot reduce at the scene because they try to bend the knee like this. So whenever you bend the knee, sometimes there's so much pain, right? And they cannot extend the knee. Whenever you bend the knee, then the patella never come back. You need to gentle extend the knee and then slowly push the kneecap back. Once you extend the knee, the quadricep will be relaxed, right? And you can easily push it back.
Actually,
No traction, just extension and push it back.